This program is brought to you by Stanford on iTunes U at Stanford University. Please visit us at itunes.stanford.edu.
Well, thank you very much. It's a pleasure to be here, and I'm hoping that will stimulate you to think about osteoarthritis and some of the related conditions that affect millions of Americans worldwide. What we have here tonight are four speakers who are experts in their field, from an immunologist and a rheumatologist to a biomechanical engineer to a biochemist and a biological researcher, who all have a very strong interest in the diagnosis and treatment of osteoarthritis, both now and in the future. Now, you may not be aware of this, but you're right now in the bone and joint decade. And it's really a focused decade for the prevention and treatment of musculoskeletal disorders. It's a global, multidisciplinary initiative aiming to reduce the burden and cost of musculoskeletal disorders to individuals, health care givers, and society. The four focus areas of the bone and joint decade are joint disease, osteoporosis, back pain, and skeletal trauma. And you can see joint disease is really at the top of the list. Now, why is that? Because it's one of the most common causes of physical disability around the world. And osteoarthritis is the leading cause of joint disease worldwide. If we look at the general population, the prevalence of joint diseases increases with age. And you can see, as people get older, knee osteoarthritis, hip osteoarthritis, shoulder and hand osteoarthritis increases with time. And you can see from this slide that our population is aging. If you look up to the year 2030, we can see the population greater than 65 is 1/5 of our entire population in the United States. But not only is our population aging, the elderly population, as we used to know it, is dramatically changing. All of us want to be active. All of us want to do things like we did them when we were much, much younger, teenagers. We all feel healthy and vigorous. Knowing all of this, the four of us had a terrific idea to help present to the Stanford audience some of our thoughts about osteoarthritis, from its diagnosis and treatment to some of the cutting-edge research that we are working on in the lab and hope to bring to the forefront in the clinical type of arena in the very near future.
The challenge here is to provide a context for what osteoarthritis is, a general sense as to what causes the disorder, how we diagnose it, and how we might go about treating it. Well, clearly, there's a lot of misperceptions to what osteoarthritis is. So I've tried to provide a definition here and then a few facts about it. Clearly, there's a few mechanical things that take place here. There's softening of the cartilage. Cartilage is the normal tissue that exists around the surface of the bone in a joint, and in many cases, as a insert, as a tissue between the bone, almost like a sponge to provide a nice soft cushion. As we get older, we see some deterioration in those normal components of the body. Particularly, we see some softening and disintegration of the cartilage in association with osteoarthritis. The second hallmark feature, we see some changes in the bone. And we see that in attempts to get around the changes that have taken place in the cartilage, the bone starts to grow. In fact, you can develop bone spurs around the joint. That growth of bone actually is one of the problems. It results in more pain and discomfort. But it's the body's normal response to try and slow down the motion in the joint. Effectively, osteoarthritis is a chronic disorder. It doesn't go away overnight. In fact, we don't have a cure for it. It's also important to recognize that it's not necessarily age-related. In fact, it can occur at any age. It's also an asymmetric phenomenon. It's often worse in particular areas of the body. It's asymmetrically distributed and often be localized to just one portion of the joint rather than to the whole joint itself. And I'll show you an example of that. And unfortunately, it often will progress in a steady fashion, leading to dysfunction and pain over time. Now, I think it's hard to understand what abnormal is until you have a perspective of normal. This is an X-ray of a normal joint. This is your femur. This is the large bone that extends from your hip to your knee. And these are the two bones that extend from your knee to your ankle, the tibia and the fibula. This is a normal knee joint. If you notice, it has nice smooth contours and a nice space in between the bone. That's a healthy joint. Over time, though, because of disintegration and softening of the cartilage, and the bone's attempt to repair itself, the knee can look like this. In fact, you can still see that this part of the joint looks nice and normal. It has a nice contour and a nice space between it. But unfortunately, this portion of the knee is obliterated. So again, the whole joint isn't destroyed, but a portion of the joint is. And I don't think you need to be a radiologist to understand that this bone is no longer functioning in a normal way. And in fact, there is no cartilage there. It is completely disintegrated. The same can be said of this side. Significant loss of the cartilage, the bone is abnormal, and even you're starting to develop what we call bony spurs. Other important things to keep in mind about osteoarthritis is that it is not, in fact, a systemic illness. There's nothing else necessarily that's going to go wrong in your body because of that. It's not primarily an inflammatory disorder. In fact, it's a process in and of itself more than it is a disease. And as a process, it really is a reflection of a disparity that's taking place because of multiple forces in the body. It's a disparity between the stress and the ability of the joint to withstand the stress. If the body cannot withstand the stress over time, it causes dysfunction, and the body's anatomy no longer performs in a normal way. So in effect, it's a balance, a homeostasis between destruction and repair. Now often, many of us think of the illness itself as either a primary phenomenon or a secondary one. When we say a primary phenomenon, we mean that there was no obvious injury to that joint at some other portion in your life. And when we say it's a secondary phenomenon, it's because we believe you've injured that joint or had some previous abnormality, either a congenital one, you were born with a slightly unusual joint, which we see in hip disease all the time, or previous injuries, which are really quite common to many people in the room. You've injured your knee at some point. You twisted it, you stumbled, you skied, you did something when you were a teenager, and you're maybe paying the price for it 10 or 20 or 40 years later. Of course, it doesn't always involve just the weight-bearing joints. It can be in your hands, it can be in your neck, it can be in your lower back. Unfortunately, it is, in fact, a universal disorder. Everyone will get it if you live long enough. It's the most common of all joint diseases and the most frequent cause of physical impairment we see in any population at any age. While it can occur at any age, only about 1% of individuals under the age of 30 suffer from osteoarthritis. But as you can see, it starts to ramp up quite quickly. 10% of the population over the age of 40, 50% of the population by age 65 and older are afflicted with this. And again, if you look at people in their 8th decade, everyone has it. Now, how often and what joints does it actually occur in? Well, the joints that seem to be the most common are the fingers. And it shouldn't be surprising. All of us stress our fingers on a daily basis. The hips, they bear a large majority of the weight. Our knees and our spine. The reason we develop it in these areas are often related to the local anatomy itself, the biomechanics of the joint, and congenital abnormalities, or the joints or the anatomy you were born with. Symptomatically, we see that about 5 to 6% of adults over the age of 30 start to begin to complain of discomfort within the knee associated with osteoarthritis, and that grows. As well, we see symptomatic complaints of the hip starting to occur in the same age group in about 1 to 4% of adults. This is what we often see. Many of you may take a look down and look at your own hands. We notice that there's these large bony growths that start to take place. These are the type of changes we see in osteoarthritis. The disparity between the stress and our ability to deal with that stress results in the bone to start to grow. It's the body's attempt to decrease the stress on the joint. But the reality is the osteoarthritis comes about because of a constellation of factors. There are a number of factors that can predispose. Certainly age, which I've alluded to, gender. Unfortunately, women are more likely to develop osteoarthritis than men. And there are racial characteristics. We also notice slight differences between different racial patterns. We also know that the genetics certainly underlie this. Some of you will be blessed with genetics that allow for repair and regeneration for a lifetime, and others are not so blessed and find, in fact, that they don't have such good reparative skills. You're born with your genes, and they certainly influence what happens as far as susceptibility. Your bone density, nutritional factors, and other systemic factors will play a role as to how this takes place and what your susceptibility is over time. But otherwise, there are local biomechanical factors. As I mentioned, joint injury, obesity. One of the single largest risk factors is what your weight is. Joint deformity and clearly muscle weakness will all play a role in influencing both the site and the severity of your osteoarthritis. Now, what are some of those risk factors? Well, again, risk factors such as age has already been alluded to. But as I mentioned, obesity, your body mass index, how heavy you are based on your size and frame, is the single largest risk factor for the development of osteoarthritis over time. If you weigh more, you are much more likely to develop this problem. That's why many of us harp so much on trying to reduce weight, even by a few pounds. Previous injury to a joint, particularly the knee, is very highly likely and very highly associated with the development of future arthritis. And if you take a look here, jogging, for any of you who go out and jog, or even walking, is inversely associated. If you exercise, if you jog, if you walk, and you basically have fairly normal anatomy, you are at less risk of developing osteoarthritis. It is a useful thing to do. Other things that I mentioned here, varus or venous abnormality, has to do with whether or not you're bow-legged or knock-kneed. If you have a deformity in that fashion, it will increase your risks. Development of calcium deposits and other generalized features of osteoarthritis also increase your risks. And for those of you who worry about this, certainly we think about it a lot in the clinic. Not everyone who has osteoarthritis shows those extensive radiographic changes. And there are plenty of people in the audience that will have very bad radiographic changes, but never have a lot of complaints of osteoarthritis. So there is always a disconnect between how osteoarthritis develops and how much of it we may see anatomically on an X-ray. Now, how do we go about treating it? Well, I've taken an algorithm from the American College of Rheumatology to talk about how we treat osteoarthritis, predominantly in the hip and the knee. But by and large, it boils down to three factors: non-pharmacologic therapy, non-drug intervention, pharmacologic therapy or drug intervention, and surgical therapy. What do I mean by non-pharmacologic therapy? Well, what I mean is patient education. The more you know about your osteoarthritis, the more you know about your risk factors, and the more you know about how you can influence your own course of the disease, the better off you are. Of course, self-management programs that teach you how to deal with arthritis can be some of the most helpful things that you can do. And they are run here at Stanford and elsewhere in the community, and they can be quite helpful at reducing your pain and improving your function. Seeing a health professional and getting other social support via telephone contact can also be helpful. Physical and occupational therapy can make a big difference to the strengthening in the musculature around a joint, which ultimately would lead to better function. Weight loss. One of the most difficult things to do is actually lose weight, but may have the largest impact to the progression of your arthritis over time. And aerobic exercise programs, assuming that you can do this in a pain-free fashion, can have a major impact on both your pain and improvement in function. And by physical therapy, what do we mean? Well, range of motion. We also mean strengthening, improving the strength of the musculature around the joint. We also mean, through occupational therapy, the use of assistive devices. Sometimes canes can be quite helpful, particularly when they're used correctly, such as being used in the contralateral hand, meaning used on the side of the body opposite of where the pain or the arthritis is. Orthotics, or shoe inserts, things that can be used to help re-equalize or redistribute the weight to areas that are not as afflicted by arthritis. And thermal modalities, by that I mean heat and cold, can also certainly be helpful symptomatically. Now, when we mean pharmacologic interventions, what are we really talking about? Well, we're talking about drugs like acetaminophen or Tylenol, topical analgesics, Bengay, Aspercreme, or compounds that include capsaicin. But by and large, the mainstay of pharmacologic therapy boils down to what we call non-steroidal anti-inflammatory drugs, drugs that many of you are aware of, such as Aleve, and Advil, and Motrin, the types of drugs that will reduce inflammation and provide pain relief, the types of things that you can pick up over the counter at any pharmaceutical place or any grocery store. There are other therapies, though, using of narcotics or opioid analgesics, intra-articular steroid injections, and last, I'll mention what's called viscosupplementation. or injections of hyaluronic acid into a joint, which sometimes can prove useful. Now, many of you will shake your head when I talk about acetaminophen or Tylenol. Many of people a priori say, or right off the bat say, gosh, that doesn't work for me. Well, it may not, but many of you may never have taken it the right way. How does Tylenol work? Well, it provides analgesia for a good number of people. Certainly, symptomatic relief has been comparable to that of nonsteroidal anti-inflammatory drugs in the past. When we say take it correctly, we mean that you need to take it 3 or 4 times per day, every day, whether you're having the pain or not. Taking it sporadically as one pill, here or there, while good intention, unfortunately doesn't result in pain relief. So most of the time we counsel our patients, if they're going to take it up to 3 grams per day in a divided dose, meaning a gram 3 times per day, can be quite effective for pain relief for many individuals. And in general, will avoid adverse effects that we see with some of our other anti-inflammatories. And usually results in minimal risks, assuming you have a normal liver, a normal kidney, when you stay below a total dose of 4 grams in a day. Now, many of you will say, and many people often reckon back and forth, well, what's better? Is Advil better than Tylenol, or is Tylenol better than Advil? Well, the reality is, most studies have never been able to discern a difference. They are very different drugs, I assure you, as far as anti-inflammatory benefit. But when looked at in scientific fashion, whether you look at a high dose of ibuprofen, or a medium dose of ibuprofen, or Tylenol at 4 grams per day, and you look at patients 4 weeks later, there really was no difference. In fact, almost the same number of patients in any group had the same response. And there were no differences with respect to being able to take it or side effects. And in fact, everybody in all of these groups got better. So for some people, Tylenol works quite well, and for others, ibuprofen works quite well, assuming you take it at a reasonable dose in an appropriate fashion. What about the issue of topical analgesics? What about drugs like Bengay or Aspercrine or capsaicin? Well, for some individuals, they can be quite useful, particularly for individuals who do not respond to oral analgesics. The application of topicals such as capsaicin, which are derived from pepper plant, can actually result in what we call a depletion of substance P. It actually results in a reduction of some of the mediators of pain in the body. It does have side effects. It can cause some local burning. You'll feel some heat and warmth in the area. And if you're unfortunate enough to put it on your fingers and get it around your mucous membrane, such as your mouth or your eye, you'll have an awful lot of pain. Clearly, you want to avoid that. But if you apply this to the joint in a routine fashion, many patients will have relief over time. I think the big issue, though, is nonsteroidal anti-inflammatory drugs. This is the most commonly prescribed medication for the treatment of osteoarthritis, and even without a prescription, it's the most commonly utilized drug over the counter for the treatment of arthritis. Certainly, at low doses, it can be analgesic, meaning it reduces pain, and at higher doses, it certainly can reduce inflammation. How do these drugs work? Well, they have efficacy because they are antipyretic, meaning they reduce fever. Many of you know that. If you had a fever and you take one of these, you'll get better. It's analgesic in that it reduces pain, and it's anti-inflammatory in that it reduces swelling and warmth. But it does have side effects. It can cause inflammation and bleeding in the stomach. It can cause problems in your kidneys, and can cause bleeding through platelet inhibition. And in fact, the mechanism by which these drugs work, such as aspirin or Advil or ibuprofen or naproxen, through what we call nonspecific inhibition of cyclooxygenase. This is a very specific enzyme in the body. These drugs inhibit that enzyme, and quite effectively. It's important to keep in mind that many of you have been marketed to, whether you realize it or not, while you watch commercials for drugs like Celebrex and Vioxx and a whole host of new compounds that are marketed to you direct to consumer, or what we call DTC, about how great your life can be if you were to take a drug like Celebrex or Vioxx or another. The reality is, these drugs work through a slightly different fashion. Well, I told you regular drugs like ibuprofen work because they're nonspecific. These drugs are often touted as inhibiting a very special enzyme called cyclooxygenase 2. This enzyme is important in the body because it's what's responsible for the development of inflammation. These drugs, at least in theory, are able to inhibit this very specific enzyme. And because it doesn't inhibit any of the other enzymes, it results in less of the unwanted side effects. And at least in theory, these drugs have very great specificity for this enzyme without knocking out the other one. Thus, they have better side effect profiles. And at least in theory, they will provide a potent anti-inflammatory activity with fewer side effects, particularly on the stomach. I would suggest to you that there is an upside to some of these drugs that you've been marketed, such as Celebrex and Vioxx, in that they probably do, in fact, have a decreased risk of side effects, particularly for the stomach, less risk of ulceration. However, there is also a downside. They're not necessarily any more efficacious than any of the drugs you've ever tried before, or any of the ones that don't specifically inhibit just that one enzyme. These agents are in fact not free from side effects, however. Maybe they have fewer, but that doesn't mean they don't have any. And of course, the important thing to keep in mind is they do not affect the course of the disease. They do not reverse osteoarthritis, and they do not change the progression of your osteoarthritis over time. So, they may provide slightly greater safety for your stomach. You keep that in mind. What about drugs like narcotic analgesics? That question comes up many times in the clinic. Drugs like codeine or profoxifene, oxycodone, or combinations of these agents with background nonsteroidals or Tylenol. Well, in general, we usually think that they're a poor choice in the treatment of osteoarthritis. They can be used for folks with really refractory disease, but in general, they often result in tolerance, nausea, and constipation, and over a period of time can also result in addiction. We use them transiently, but they are not a long-term or good goal strategy for the treatment of osteoarthritis. There are other analgesics that sometimes can prove useful, drugs like Ultram, also known as Tramadol. It may have less side effects of some of the other opioids and can have pain-relieving properties, but again can also result in mild nausea and constipation, and is often thought of as a slightly useful adjunct for the treatment of osteoarthritis, with less of the downsides of some of the previous narcotics or opioids I mentioned. Questions come up all the time about the use of steroids. What about injecting steroid into a joint? Well, it actually can be quite useful and not often very detrimental. In fact, we don't believe it has a great deal of detriment when done appropriately. It's particularly useful for patients that have swelling, what we call an effusion, local signs of inflammation and fluid accumulation in a joint. If the doctor is to aspirate or remove the fluid from the joint and then inject steroid after that, one can see often an improvement. Now, sometimes that improvement only lasts a few days, and sometimes it's fortunate enough to last several weeks. It can have some potential downsides, in that it may actually inhibit some of the metabolic and anabolic function of the cartilage. By that I mean some of the normal healthy functions of the cartilage, so you don't want to do it all the time. Certainly, in animal models, it's proven somewhat destructive if it's done repetitively. So in general, we believe that you can have a joint that is otherwise swollen or affected by osteoarthritis injected up to 3 to 4 times per year, assuming it's providing relief, and not necessarily resulting in any significant detriment to the cartilage. There's in fact another alternative to be injected in a joint that's called viscosupplementation. Any of us have fluid in our joint at any given time. That fluid in and of itself is called hyaluronic acid. It's a normal component, a normal product of the body. Fortunately, you can actually produce this synthetically in a lab. And for an appropriate individual, this can be injected intra-articularly, once a week over 3 or 5 weeks. And these drugs are generally thought to be slow-acting, and they generally don't modify the course of the disease. But for some patients, on the neighborhood of 25 to 50% of the patients who get these injections will get a significant improvement. They'll have less inflammation. They may, in fact, have slightly better lubrication within the joint. And overall, it may stimulate an effect on the cells that line the joint to start to produce more normal fluid. Now, many of you will ask about nutritional supplements. What about the things that can be purchased at your GNC store or at your local supermarket? There are lots of things out there. I've only named a few. Things like chondroitin sulfate, glucosamine, ginger-based products, shark cartilage, MSM. I could go on a list of many. The reality is, none of these drugs have ever been proven in any studies to be significantly useful in the treatment of osteoarthritis. It's important to keep that in mind. And given the fact they're not FDA-approved drugs, they never have to go through those sorts of trials. Now, with that said, there are many of you that will find that you'll get some pain relief with the use of chondroitin or glucosamine. And I think that's great. I often advise my patients if they want to take it. I don't see that there's a large downside. Many of you will get improvement, and I think that's quite useful. However, you shouldn't necessarily confuse improvement in your symptoms with structural change. Many of these bottles can be seen at the grocery store or at Walgreens or Long's, and it says it repairs or helps your cartilage. I think you need to be fair and recognize that that's simply marketing. there is no proof that these drugs actually cause your cartilage to heal or regenerate in any way, shape, or form. Now, that doesn't mean they can't cause pain relief, but they are not healing your cartilage. So you can take these drugs for 3 or 4 months, and if they have benefit, there's no reason why you can't be on them. If you've tried these for 3 or 4 months and you don't feel any better, I think you probably can find a better use of your disposable income. Newer therapies. Of course, people always bring this up. Well, what's on the horizon? What's the next wave? What are the alternatives in the future? Well, we think of them as chondroprotective agents. We think about things that might actually help protect your cartilage, cause it to live longer or function better. There are lots of drugs that are under study, including what we call MMPIs, or matrix metalloprotease inhibitors. Some examples of those include things such as tetracycline antibiotics. Many of you have heard that taking a tetracycline-based drug, such as minocycline or doxycycline, is good for your arthritis because it kills the bacteria. Well, it may be good for your arthritis, but not because it kills any bacteria, I assure you. If it works, and it may work in some patients, is because it's modifying very specific enzymes in your joint, not because it's killing any bacteria. There are other medications that have been tried, drugs like Fosamax or Rezidronate that inhibit osteoclasts. Those are the cells that break down bone and cause osteoporosis over time. May have a very mild impact on osteoarthritis. But there are a number of things under development right now, including growth factors, anti-cytokine therapies, and inhibitors of other major metalloproteases in the body that may in fact prove useful. Unfortunately, they're not going to prove useful tomorrow. They are in clinical trial and on the drawing board for clinical trials in the next few years, and hopefully may present a potential therapy 5 years and a decade from now as far as being commercially available. Now, there are in fact other alternatives, including surgical therapies. And I at least want to mention the fact that arthroscopy can be performed. The joint can be washed out. Damage to the cartilage may be able to be repaired. Loose pieces can be removed, or even large chunks of cartilage, when necessary, can be removed. When appropriate, the joint can be replaced. And when necessary, other unique types of cartilage transplantation can be considered. All very highly technical skills, all of which have to be the unique procedure for a very unique individual. But in general, the treatment of osteoarthritis boils down to this algorithm. The non-pharmacologic therapies, what you can do to help yourself. The pharmacologic therapies, including the medications and the topicals I mentioned. And then the surgical alternatives for those patients that continue to have poor function or considerable pain.
We just had a recent meeting of the Orthopedic Research Society here in San Francisco, and I loved the way they framed it and said it all begins with research. And really, a lot of the answers to these questions begin with basic laboratory research that can be moved to the bedside and various hypotheses tested and eventually applied to treatment and hopefully prevention. My area of interest is related to the mechanical forces that act on cartilage, but I would like to take a step back and look at how these all interact with one another in terms of both the biology and the structure of cartilage. So just with that brief background and the background provided by Mark and Stuart, I'd like to move on to talk a little bit about some of the current research that has been done in my laboratory related to mechanical factors and an analysis of how the mechanics of the joint influence both the prevention and the treatment of this disease. And one study in particular that's of relevance to this question is one in which we analyzed the mechanics of the knee in a condition called varus alignment, or a bow-legged deformity, as illustrated here. Many of you may have this condition as we age, or a number of people are born this way with the knees not in perfect alignment, but with a slight bow-legged deformity, as shown here. Typically, that condition is associated with arthritis in one portion of the knee joint. And this is a similar x-ray to the one that Mark showed earlier in his presentation, where the cartilage is beginning to thin in one portion of the joint here, which is a medial portion of the joint. One of the methods to treat this disease is to surgically realign the limb to a more anatomically correct position, as shown here. This procedure, which is described as a high tibial osteotomy, really is a procedure where there's a surgical reconstruction of the limb so that it's straightened out. We've been studying that procedure for a number of years and tried to identify which factors influence the outcome of this surgical procedure. And what we found is something interesting. If we tested patients that had this varus or bow-legged deformity before they had the operation, but tested not just their alignment statically when they're standing there, but dynamically when they're walking, and measured the forces, which we can do in a gait laboratory, while they're walking, those forces that were exerted on the knee before walking were the most predictive of who would do well with this procedure. And it turned out that patients that walked in a way that modified or reduced the load on that part of the cartilage that was damaged tended to do better with this procedure. And here, I just animated this skeleton to illustrate a point, really. It's interesting to look at that skeleton, but if you notice when he's walking, the upper body is swaying back and forth a bit. That can change the way the loads are exerted on the knee, the hip, and the ankle. In addition, depending on foot placement, we can affect the way loads are placed on especially the knee joint. I'll talk a little bit about that more later. So that within a normal population, if we measure, say, if I measure everybody in this room in my laboratory, I would see a pretty substantial distribution in the way you generated loads at your knee joint. And depending on that, there's a higher probability, depending on the way you walk, of whether you'll progress more rapidly into osteoarthritis after the disease begins to manifest itself. And if you do these types of analyses, you'll see that there's a large variation in what we classify as normal walking, but typically the loads that are exerted on the knee during a simple activity like walking can be 3 to 5 times the weight of the body. And we also find that if we look at patients that have osteoarthritis, that those with lower loads on the knee, in particular that one portion of the knee, which is called the medial portion of the knee, the walking will affect the rate of progression. And this information was derived from a fairly large study that we conducted of patients that we brought into the laboratory that had early stages of osteoarthritis of the knee. Not severe enough to need operation or even any drastic intervention, but had arthritis. And when we measured the loads on the knee during walking, we found that the thickness of the cartilage was reduced as the loads were increased. So if you go horizontally along this graph, it's load on the knee joint, and if you go vertically, it's thickness of the cartilage. So you can see as a line goes down, cartilage gets thinner with increased load. This is in patients that already had knee osteoarthritis. If we took a step back and looked at the bigger picture in terms of the mechanobiology of articular cartilage and tissue in general, typically the body responds well to load. If we load and exercise more, we get stronger, our muscles get more bigger, our bones get denser, and in essence, we would expect also the cartilage to get thicker with mechanical load. And in fact, if we look at healthy cartilage in the laboratory, what we see is that cartilage thickness increases when we apply contact pressure to the joint. So that if we take purely laboratory studies or mechanobiology studies, if you want to call them that, we have a paradox between what we observe clinically and what we see in the laboratory. So, and it begs the question, does load on cartilage help or hurt cartilage? And is it the cause or the effect of OA? So that led us to another series of experiments on actually people with healthy or normal knees. And we used some of the technology which is available here at Stanford to get very detailed images of the cartilage of healthy knees. This is just a schematic of scanning of an MRI where you take individual two-dimensional slices. And what we can do is put those slices together and reconstruct the three-dimensional anatomy or geometry of both the bone and the cartilage in the joint as illustrated here. But what's more important, we can actually, from that information, derive the thickness distribution of the cartilage on both the femur and the tibia. So this is the upper diagram here is the femur looking from the top down, and the lower one is the tibia. The darker areas indicate, the blue areas indicate thicker cartilage. As you go to red, it's thinner cartilage. And what we see when we look at healthy cartilage and we look at the load-bearing areas of the knee during walking, the thickest cartilage is in the areas that bear the most load during walking. Now, this is consistent with the experiments we saw, that cartilage gets thicker and responds to load. But this wasn't consistent with these clinical observations we had. So what we began to look at is both healthy knees in the Gait Laboratory and knees with osteoarthritis. And again, we used our imaging methods to quantify the thickness on the medial and lateral sides. And sure enough, what we saw is for healthy knees, the thickness of the cartilage increased as the loading during walking increased. So someone that exerted more force on their knee during walking, or perhaps did jogging as an example, had thicker cartilage in our leg. So more active people had thicker cartilage, which goes along with that, some of the epidemiological data that Mark showed in his presentation, that people who jog actually have a lower incidence of osteoarthritis. Now, when we looked at patients that already had osteoarthritis and we looked at the thickness, as you can see here, this patient had substantial loss of the cartilage on the medial side, which is with that. We see the inverse relationship. So there's a different mechanism that takes place after osteoarthritis starts in the knee joint that you have to be aware of. So cartilage thickness decreases as load increases. Now, the exact mechanism of this is something we're pursuing in the laboratory right now, but sorting out these observations between being able to differentiate between the way healthy cartilage responds and osteoarthritic cartilage responds to load turned out to be a critical step in moving to the next set of experiments we're doing. So just to summarize, the blue line shows healthy cartilage increasing its thickness with load, osteoarthritic cartilage decreasing its thickness with load. But again, this begs the question, well, what is the cause of osteoarthritis? It does not look like increased loading is a factor in causing the initiation of osteoarthritis. It influences the progression. Once you have osteoarthritis, loading will make it progress more rapidly. Another big area of research in my lab, which started out particularly related to sports injuries, has melded into helping us to understand factors that cause the initiation of osteoarthritis. And we've been looking at the anterior cruciate ligament injury, which is a common sports injury. It happens in skiing, basketball, soccer, even in which are non-contact type sports. One can rupture the anterior cruciate ligament. There's 80,000 of these types of events per year. It's most frequent in the younger age population, but it's directly, in the long term, a factor influencing more rapid initiation of osteoarthritis. And it seems to be related not so much to the forces that get generated, but the abnormal motion and instability of the joint. And there's been a number of papers that have demonstrated in patients that have had a rupture to the anterior cruciate ligament of the knee that there's more rapid and earlier initiation of osteoarthritis. We can even go one step further. In the absence of, say, a traumatic event like an anterior cruciate ligament, there's a number of studies that show that generalized joint laxity increases the incidence of osteoarthritis. Postmenopause typically is associated with increased joint laxity. So the incidence of osteoarthritis in women is typically a factor that may be related to this increased joint laxity as well as other factors. The last thing I'd like to talk about is how this can be applied to something you are currently doing and thinking about, and perhaps an early intervention. As I said earlier, after the initiation of osteoarthritis, we can slow the progression if we can reduce the load on the joint, especially during walking. Now, from a number of studies in our laboratory, we found that one of the ways of reducing the load on the knee is controlling the foot position in different angles. Mark mentioned briefly the uses of orthotic and wedges. We've gone into a little bit more depth in that area and looked at actually the redesign of shoes that might help the progression of osteoarthritis. There's currently an ongoing project that we're developing with Nike, who has become very interested in now designing a walking shoe that can help to slow the progression of osteoarthritis. What we've looked at is a variety of different designs by testing individuals in the laboratory, and these designs include different shaped wedges and different configurations of the foot that the shoe can induce to control the loading on the knee joint. As you can see, if you look at number 5 over here, it's a rather extreme wedge. It has a fairly substantial effect. The lower the bar is below the axis, by the way, the more the shoe reduced the loading on the knee joint. So you can see that pairs 3, 4, and 5 substantially reduced some of the loading on the knee joint. Even pair 2, for that matter of fact. However, pairs 4 and 5 had a wedge that was quite uncomfortable and couldn't be worn for a very long period of time. But what we found is that we could produce the same effect in a shoe by not having a wedge at all, but by modifying the structure of the sole of the shoe, as indicated in this diagram here. We just vary the material characteristics of the shoe, which induces change in the walking. And that shoe is both comfortable, or at least is more tolerable than the wedges, and provides the same reduction in loading. With this encouragement now, we are going on to do a fairly large prospective study to see if these types of shoes will slow the rate of progression, both in terms of symptoms, based on evaluation of pain and use of analgesics, and using that MRI cartilage mapping. We're going to look at changes over a year in the rate of progression of the disease based on cartilage thickness. We're just about to embark on this study over the next 3 or 4 months. Take-home messages from this presentation. If you have a healthy knee, keep walking, exercising, load it. It's good for it. It makes it better. Loading enhances cartilage. But watch for conditions that lead to instability. If your joints start to become unstable, that begins to enhance a risk factor even under normal conditions and seems to be one of the initiating factors. If you've got some early symptoms or have been diagnosed with knee OA, loading is a factor. That 3 to 5 times the body weight during walking can influence the rate of progression of the disease. After OA starts, any way you can modify walking mechanics to lower those loads, either through gait retraining or orthotic shoe intervention, can help. Reduction in weight. You know, look at this 3 to 5 times body weight. If you reduce your body weight by 20 to 30%, you're going to reduce that load substantially on the joint too. That's why, that's a mechanical explanation for why obesity is a major factor in the progression of osteoarthritis. In the future, we're trying to integrate more of these pathways and looking at the body and the in vivo system at a systems level where we can understand these interactions to a greater extent. And we're putting together a framework where we are looking at both the biology, the mechanics, and the structure of the joint to get at a more fundamental understanding of the causes, the factors that influence the progression of the disease, and ways of improving the treatment. And Lane, I think, now is going to talk some about the biology and the biochemistry of the joint, which interacts with a lot of the things I've been talking about.
Heard previously the conditions that define the disease, and Dr. Andriacchi, I think, very eloquently explained some of the biomechanics parameters. So I'd like to focus in this talk just on the biochemistry. I'd like to start by reminding you that articular cartilage is essentially 2 to 3 millimeters thick, and it's as you heard previously, the load-bearing function. I like to refer to it as 2 to 3 millimeters of happiness. You basically get it once in your life, and as you'll hear, obviously it's a major challenge. It's basically been described as a tissue that does not repair, and for all practical purposes, that's true. What we'll talk about tonight are some methods that we think we can use to try to stimulate repair. So I have included on this slide actually images from magnetic resonant imaging that shows the articular cartilage here demonstrated in white. Now, these really represent new methodologies for looking at articular cartilage, and by using specific algorithms, this tissue shows up. Some years ago, you wouldn't be able to image that cartilage, but it gives you a clear picture. And the image on the bottom, unfortunately, shows us what happens actually early when we have a defect in the articular cartilage, as indicated by this arrow. And it's at that point now we have a rupture in this smooth, normal, weight-bearing surface, and unfortunately, there are consequences. From a biochemical point of view, articular cartilage is essentially composed of two major molecules. The aggregans, these are large aggregating proteoglycans, are composite molecules that actually have a protein core to which there are actually sugar side chains. And the reason you buy chondroitin sulfate is that chondroitin sulfate is an integral part of this molecule. The chondroitin sulfate on the molecule, unlike what you eat, serves its purpose because those chains are attached to the molecule. The sulfate groups provide the negative charge. The negative charge, together with the water, provides the compressive resilience to the cartilage. So if you don't leave with any other thought from tonight, it's these large aggregating proteoglycans that are depicted here in an electron micrograph that, when they're present in the articular cartilage, actually provide the load-bearing properties. And unfortunately, those are the molecules that are first to go. And we've done work over the years of different models, and we have for example, in an infected joint, we know that 40% of those molecules are lost from the joint within 2 days. And even if you start with antibiotic, within some number of hours, those molecules are still lost. So you can imagine, if I've just told you those molecules are essential for the weight bearing, that loss of those molecules is obviously critical.